It's a great pleasure to be with you at the fourth Scientific Summit on tobacco, speaking on tobacco harm reduction, novel products, and the research and policy. I've spent a lifetime working towards a smoke-free future, as has Professor David Kayatz. I'm going to talk today about the history of where we've come from and where we still are, and how we have to help the patients who are continuing smokers to quit or to reduce the harm of continuing smoking. Let's look at the situation in the UK. The government target is to be smoke-free by 2013, and they define smoke-free as less than 5% smoking prevalence amongst adults. We're not on track to meet this target. There's wide variations in smoking prevalence across this country, great inequalities, and Cancer Research UK says that we won't be smoke-free until at least 2037. And a personal view is it's going to be longer than that. The tobacco control strategies in education have worked, and I'm going to show you that. They've significantly decreased the prevalence of smoking in the UK and worldwide, but there still remains a significant number of smokers. The left-hand panel that you can now see looks at the history in the UK of smoking reduction. And you can see through the 60s, 70s, 80s, the 2000s, 2020, that we have significantly reduced smoking rates. And that's due to various fiscal and other policies. We stopped advertising, we've increased the price of cigarettes, but you can see there are plateaus in these significant decreases in smoking prevalence. Nevertheless, 14% of adults in the UK continue to smoke, and that is estimated at 6.9 million continuing smokers. If we look at how smoking disproportionately falls on the underprivileged, this slide shows it. If you look at the left panel as you're looking at the screen, you can see that professional and managerial classes, we've reduced smoking to 12%. But as we go down and we look at workers in labourers and bar staff, you can see it remains at 28%. So there's very significant disparity where our lessons concerning smoking are sitting and who has responded. So we have to ask, what can we do? Can we do anything? Can we do nothing? Should we continue to say, it's up to you, quit or suffer the consequences? Well, you can look on the next slide at what might be prohibition, eliminate smoking. And we tried that with alcohol in the United States in the 20s and 30s. And I think all of us know that alcohol continued to be taken. Tobacco control aims to influence behavior rather than ban it. Policies vary by country, and the Global Convention entered into force in 2005, said we should all look at this as a group of nations trying to drive down smoking together. Currently, there are 181 parties in that convention. So we have to say, does it work? Let's look at another issue we had and whether that worked. So we had the problem of harm reduction during the AIDS epidemic. And Mrs. Thatcher, our Prime Minister in the 80s, was not known for her kindness or thoughtfulness. However, she did sanction, during the AIDS epidemic, needle exchanges and safe havens, giving us the lowest rates of HIV in drug users in the world. So over the past 12 years, the UK think tank Centre for Social Justice led change in that drug policy, saying we should have an abstinence-based policy. And unfortunately, the drug-related fatalities have doubled since 2011. And now, from the lowest rate of drug-related fatalities in Europe, 1 in 3 drug-related deaths in Europe are now in the UK. So what I come to as a statement from this is people make poor lifestyle choices despite suffering negative health effects. And the headline in the Times in September the 2nd, 2019 was "Misguided Morality is Denying Help to Drug Addicts." So there's many ways of looking at what in Britain is still an illegal process of drug addiction, intravenous drug addiction, and yet you must help and prevent those terrible diseases that can spread with infected needles. So let's look now about quitting tobacco. Quitting tobacco smoking is by far the best option. But we have to look at whether innovation of less harmful alternatives could play a role in harm reduction. That is saying, you shouldn't smoke. I don't want you to smoke. I'm going to ban smoking in public spaces. I'm going to ban smoking in cars. If you have children with you, I'm going to ban smoking in transport. But nevertheless, we have to play a role in trying to find less harmful alternatives. So the innovations that have come in, of course, we all know about, are the e-cigarettes and heated tobacco products. So in this way, the smoker will have nicotine and will not die of the products of combustion. So cigarette smoke causes diseases, including cancer. We all know that. As I said, it started with that very good paper in the doctors in Britain run by Dolan Hill. Burning tobacco generates smoke. Tobacco smoke has over 6,000 chemicals in it. It contains ultrafine particles. 93 of these are listed by the USA FDA as harmful and potentially harmful constituents. The majority, almost 80, are carcinogens or potential carcinogens. So there we have it. You should not smoke. You must not smoke combustible cigarettes. What can you do with these new products? Are they only a substitute, or could they help you stop smoking? So there has been a Cochrane review, and these Cochrane reviews are very thorough. And the heading of the Cochrane review is Electronic Cigarettes for Smoking Cessation. The review, which was updated in April of this year, included 56 completed studies. It represented 12,800 participants, and 29 were in randomized clinical trials, the gold standard. The conclusion of the Cochrane review is there is moderate certainty evidence, so everything is small numbers and we have to interpret the data. There's moderate certainty evidence that electronic cigarettes with nicotine increase quit rates compared to electronic cigarettes without nicotine and compared to nicotine replacement therapy, which is what we essentially had before. We did not detect, the authors say, any clear evidence of harm from nicotine electronic cigarettes, but longest follow-up was 2 years, and the overall number of studies was small. So no one's saying we've got complete guarantees, but we're saying at this early stage, the evidence does point in the right direction. We also have other evidence, and this has come from the FDA in America, which reviewed all the evidence concerning heat-not-burn product, IQOS. It determined that the exposure modification order for IQOS would be appropriate. So you could start to market IQOS to promote the public health, and it is expected to benefit the health of the population as a whole. They state the obvious: no combustion in IQOS. IQOS emitted reduced levels of toxicants than cigarettes. And if we look to the right-hand panel, you can see that acrolein is down by greater than 90%. The benzpyrenes are down by 90%, formaldehyde down by greater than 80%. The nitroso nicotинosides down by 92%, and the ketone nicotинosides down by 98%. IQOS has a lower toxic potential than cigarettes, and although risk reduction has not yet been demonstrated, a substantial and measurable reduction in morbidity and mortality is reasonably likely in subsequent studies. So FDA made a pretty powerful statement there. They looked at the evidence, they've reviewed the evidence, they've remeasured the evidence, and they do think that there's evidence that it's contains significantly less toxicants. So if we look at this adapted from Stevens in 2017, and we look at the mean lifetime cancer risk ratio to smoking, and we put at 1 cigarettes to the right of the screen, you can see that nicotine inhalers are down at 0.000, that e-cigarettes are very adjacent to that, and that heat-not-burn products are very adjacent to that. So he said the cancer potency is not really a risk continuum, it's not really a gentle slope, but a risk cliff. So at the levels which you are having from these products, it does look as though there's going to be much lower risk. How do we end this talk? It's clear that we have to encourage quitting. It's clear that smoking is not good for you. But we have to answer the needs of a population who cannot or will not quit. So we have to approach harm reduction in this position, just as we did with other subjects, just as we put in seatbelts in cars and airbags in cars to protect you from collision. We need to cut through the confusion and rhetoric. We need to address the needs of continuing smokers. We need to help as many of them as possible to stop smoking cigarettes. We've got to protect the youth from exposure to and the use of these products. So we have to look very carefully at whether these products could be a pathway into smoking combustible cigarettes smoking. There's no evidence for that. The products have been looked at very carefully. A spectrum of products is needed with regulation in place that is proportional to the risk of those products. Sales and advertising of the products has to be restricted to legal age users. You must allow accurate and truthful information and warnings relative to cigarettes that consumers understand. You therefore need to accept that these products have a role, and then you need to control how we market and sell these products. But I think the end result will be a better place, and that of the remaining smokers, and I've said in the UK 7 million, of those remaining smokers, we should be able to reduce their risk and help them to avoid disease. Thank you.